Friends, today I'll be discussing syndromes in acne. And somehow acne is not very taught so rigorously in postgraduate training because acne doesn't normally come as a question in the practical exams. Right. So then we come to the scenarios and discuss these syndromes, and I call them the scenarios that I hope no one faces because they are tough to diagnose, even tougher to treat. But the idea is to pick them as early as possible. So here's a classic example of a severe syndromic acne. And if you see this patient's photograph, what you will realize is that what he has on his face is a residual scarring, a lot of keloidal scarring, a lot of atrophic scarring, and then you see lesions on the back which have acneiform lesions, and plus has got multiple large succinate plaques and a lot of erosions and crusting. And if you see them very carefully, and if I give you an historical depiction, this basically patient had a long history of persistent erosions on the back, and what you see on the back actually is not just acne but also something beyond that, and which I'll of course discuss in the next few slides. So there are, two kinds of narratives in medicine: the lumpers and spitters. So lumpers are people who club multiple entities into one, and spitters, of course, are the guys who keep on dividing one entity into another one. So, for example, there are people who split, say, for example, psoriasis into multiple subtypes. Some lump it into a few. So historically, it's said that economists are lumpers and psychologists are splitters, and so that actually applies to syndromes in acne. Now, the other syndrome in acne, and this is the classification that I use. The first, of course, hyperandrogenism, which I'll discuss in another lecture. Then you have these, syndromes like PAPA, SAPHO, APERT, and acromegaly, out of which we will try to focus on the PAPA syndrome complex. And a lot of these conditions, of course, are, PAPA syndrome complex. Right, so we'll begin with the syndromes, and I'll begin with the first syndrome, that is PAPA. Now, PAPA is the main syndrome which you should understand, and the rest are probably variants of that. So, PAPA has got psoriatic arthritis and PG and acne, and another syndrome that is like PAPA with the same gene mutation is got, in addition, ulcerative colitis. Now, if you add hidradenitis suppurativa to this particular syndrome complex, you've got two more syndromes, and the papash and the pash, and of course the second one has got seronegative arthritis. Notably, these two syndromes do not have pyogenic arthritis, which is seen in papa. Then if you add arthritis to this whole complex, you can have two different sets. One is the one with psoriatic arthritis, a second with pyogenic arthritis, and then of course you have the one with axial arthritis. Now, essentially this is a classic splitting, and for an average clinician, of course, it's going to be difficult to remember this. So for a clinician, what you should look for is when you have a patient who's got acne with a combination concomitant or preceding hidradenitis suppurativa, arthritis, or PG, you can think of these syndromes. Now, here's a classic case of a syndromic acne, and what you see here is pustular rash all over the body, which is diagnosed usually as pustular psoriasis involving the palms. So a combination of pustular psoriasis of the trunk and the palms, and of course the patient has got a bit of acne, and these patients have classically, pain in the sternal area and also back pain. Here's a depiction of the syndrome. So you have predominant palm and sole involvement, and then you have these images that show involvement of the axial arthritic areas and also the back. And of course, the important thing in all these syndromes is that you should be able to identify the cytokine. And here the cytokines have, there's an array of cytokines seen: TNF alpha, interleukin 1, and of course IL-6, 10, and TGF beta. Basically, if you look at this cytokine value, it's more like a TH1 response with also an IL-1 response. And of course, the importance is you got to target these cytokines for a treatment response. So the overview of SAPHO is there's a combination of aseptic articular arthritis, acne, pustulosis with hyperostosis. Mild cases are usually missed out. The skin has got, of course, predominant acne fulminans and hidradenitis suppurativa. The most common skin issue is palmar pustulosis. There's a marked anterior chest wall involvement, and the main cytokine seems to be TNF alpha. But because there are so many cytokines, you can try other drugs also. And the important thing here is that when you treat the autoinflammatory syndrome with biologicals, the acne may not respond
in fact, and vice versa. So you got to combine therapies for both the acne and the syndrome by itself. And one should, of course, avoid astretinoin. There are paroxysmal flares in SAPHO. So the essential part is the fact that the biologicals don't necessarily improve the acne goes to show that maybe it's only an association.
So this is the next case, and what you see here actually is a photograph of a patient who's got visible keloidal scarring on the face with a persistent erosive lesion, and on the back also you have multiple areas of atrophic scarring with active lesions that are erosive clustered plaques. And this patient, of course, has got uh, severe acne and a recurrent arthritis history, which was there at an earlier age. And of course, what you see on the back is actually lesions of pyoderma gangrenosum. Now, these this condition and the conditions which are around it are actually auto-inflammatory syndromes, where there is excessive activation of the immune system with recurrent fevers and presence of neutrophilic dermatosis, and of course an acne, which is the reason why they are usually diagnosed. So Papa syndrome, of course, has got a combination of recurrent steroid arthritis that actually begins in childhood and then decreases in puberty. And then, of course, you have a positive pathology test, abscesses, severe acne. The cytokines that play a role in this particular syndrome, arise from the mutation that leads to a typical pathway that is seen in various disorders which are autoinflammatory. That is a pyrin, interleukin 1 beta, IL-18, interferon gamma, a feedback loop that actually attracts neutrophils, and the cytokines which are also seen here are of course TNF alpha with IL-1 and IL-17. So relevance, of course, therapeutics, you can target biologicals or with JAK inhibitors. So the overview of the Papa syndrome begins in the first decade of life. The initial history is actually fever, recurrent aseptic purulent synovial arthritis. Involves usually the ankle, knee, and elbow joints. It's post-articular, and when the joints condition improves, acne appears, and that's when probably we come into the picture. There is marked regions of PG involving the extremities, and of course, as I told you previously, the therapy is usually around TNF alpha, but now of course you can try JAK inhibitors. So this was the index case. We published this paper a few years back. In those days, we did not have JAKis, or biologicals were very costly. So we combined three commonly used drugs to target the commonly involved cytokine axis in this particular condition. And of course, this patient improved. So you can treat a patient without even giving biologicals. And lastly, of course, overview of treatment of the other conditions. Usually anti-TNF alpha and IL-1 is what are given, but the data on the other disorders is not much. So with that, I close my lecture on syndromes in acne, and the whole purpose of this lecture was for you to diagnose conditions that probably are misdiagnosed by other clinicians. Thank you so much.